Okay. So the elbow joint, it's an articulation between the distal end of the humerus and the proximal end of the bones in the forearm, which is the radius and the ulna, right? So in terms of articulation, we generally divide the articulation into a humero-ulnar and a humero-radial articulation, right? So here we can see this is the distal end of the humerus. This here is the ulna. Then this is your radius with that rounded head there, right? So we have one end which is going to be humero-ulnar. Then the other end is humero-radial, right? Those are the two articulations that we have at your elbow joint, right? It's going to be a bit different when we do the knee joint. There's an additional articulation at the knee joint, right? Then type of joint, this is a synovial hinge joint. And by hinge, we mean that it's uniaxial. It can only move in one axis, like the hinge of a door. So you can only flex it and extend. Which muscles flex? The main flexors for the elbow joint are the muscles in the anterior compartment of the arm, particularly the biceps brachii and the brachialis. Those are the two muscles that will flex here, as well as other muscles in the anterior forearm, but those ones are weak flexors of the elbow. Does anyone know why I didn't mention the coracobrachialis? Yet it's a muscle of the anterior arm.
It doesn't cross the elbow.
It doesn't cross the elbow, right? So coracobrachialis is quite small, and it only crosses the shoulder joint. And when it does cross the shoulder joint, it's going to be a weak adductor, right? Okay. So I've told you the type of joint, movements possible there. It's flexion and extension. Um, I'm talking about muscles that effect those movements. The main extensor will be the muscle for the posterior arm, which is the triceps. Remember, the triceps will cross the elbow joint as it goes to its insertion on the olecranon process of the ulna, right? Okay. Then which bones are articulating? I've told you the humerus, the ulna, and the radius, right? And what are these articular surfaces, right? So on the humerus, on the radial side, there is something that we call a capitulum. On the ulnar side, there's something called the trochlea. So I have trochlea, I have capitulum. This is on the humerus, right? And if you look at the shape, the capitulum looks rounded. The trochlea here looks almost like a pulley, right? Okay. Then lower down here, the trochlea will fit into the trochlear notch of the ulna. I'm sure you guys must have had gone for some dissection before, where you actually got to see these things. Then I think you can see the rounded head of the capitulum, or the rounded contours of the capitulum. They will articulate with the upper end of the radius, basically where there is the head. Right. So for every ligament, I must have mentioned this when we're doing the shoulder joint. For every ligament, we have things that give it stability. It can be ligament. For every joint, rather, we have things that give it stability. It can be ligaments, it can be muscles, it can be the articular surfaces. For example, for shoulder joint, what gave the shoulder joint stability with the rotator cuff muscles mostly. For the elbow joint, what really gives it most of its support, it's it's the shapes of the articular surfaces where there's some bit of congruence where they fit into each other. Right. Then, so this is a synovial joint. Back then when I was lazy, I would just say all joints in the upper limb are synovial. It's not a true statement, but you can take it religiously to say most joints that are described by books, they're synovial. But when you really go back to the basic definition of a joint, you find that the joining of the radius and the ulna using the interosseous membrane is a form of a joint, and that's not synovial, but rather fibrous. Right. So, but generally speaking, joints in the upper limb are going to be synovial. You now need to classify the synovials. Is it synovial hinge, like the elbow? Is it synovial ball and socket, like the shoulder? Or is it synovial ellipsoid? For example, the wrist. Right. Okay. Okay. So for our elbow joint, right, we are going to have what we call the capsule, the joint capsule, right? And usually joint capsules are simply going to be cartilaginous, maybe not cartilaginous per se, but it's more or less of a fibrous sac, right? That encloses the joint cavity, right? Then on the inner surface of the joint cavity is this, I don't know if this looks pink or purple, the synovial membrane. And inside the synovial membrane, that's where you're then going to have synovial fluid. Right? Okay. Then it would also be nice if you guys would look up the attachments of this capsule. You need to look at it above. Where does the capsule attach? And I'll take you back here. Above the trochlea, there's a coronoid fossa there. Above the capitulum, there's a radial fossa there. Right. Okay. So where this capsule is attached, it attaches above those two fossa. Right? That's something worth remembering. I won't bore you with the rest of the attachments of this joint capsule. Right? Then the joint itself is going to have what we call collateral ligaments. And the collateral ligaments are two in number. There is one that is from the lateral side, which is going to be the lateral collateral ligament. People prefer to stigmatize it to say radial because radial is now more understood to be lateral, I guess, than ulnar. Then the ulnar collateral ligament is the medial one, right? And which one do you think is stronger, the medial or the lateral collateral ligaments? Ma?
I think it's the collateral ligament.
You think it's there? So I didn't get your answer.
Collateral ligament.
The what?
Okay, question which ligament is the strongest, right?
Which one is stronger between lateral and medial collateral ligament? Okay, please find out on that. As well as their shapes. Let's not guess. So they are triangular in shape. But the difference in the triangular bit, does anyone know the difference with the shape? They're both triangular, but what's the difference? Anyways, let me just tell you guys since no one is responding. So I'll draw a triangle. You remember I said they're triangular in shape. So this is more likely going to be lateral collateral ligament. But for medial collateral ligament, it is an anterior part. Then there is a posterior part. Then there's a part that joins those two. That's the difference. They're both triangular, but the medial collateral ligament is made up of those bands, as opposed to the lateral collateral ligament, where you don't necessarily have different bands, but just one ligament with a particular shape. Right. I also won't bore you with going in depth with these ligaments, but one thing that I want you guys to realize is when we're doing shoulder joint, maybe I may have forgotten to give a statement which says the capsule of the shoulder joint is thin and lax. Laxity meaning it we can now basically okay, it's not limited. Maybe if I use that word. For capsule for elbow joint, remember you can only flex and extend. So since you can only flex and extend, right, that means the capsule of the shoulder, of the elbow joint rather, it's going to be thick, on the sides where there is no movement, but on the anterior aspect and everything else, by everything else I mean posterior aspect, it's going to be thin because you want to move it anterior flexion, posterior extension. Right? Then I told you what gives it stability, right? It's the size, the shapes of the articular surfaces. Right? Would you guys want to know relations of the elbow joint? I'm sure you know. Anteriorly, there are things in the cubital fossa. Posteriorly, there's the olecranon. Okay. You remember the contents of the cubital fossa?
Yes.
Okay, those things are also going to be anterior. Then we have bursa that are associated with the elbow joint. I'll also not talk about that unless it was specified for you. Right. Then blood supply for the joint, you think of any blood supply, right? And think of any blood supply that crosses the joint. It has to cross the joint. What we call it must have been called Hilton's law. You can cross check it. Okay. So a very clear or easy example is the brachial artery, because remember in the cubital fossa, that's where brachial artery will bifurcate. Okay, so you have that. Then other branches like collaterals from the radial and the ulnar. Okay, the nerve supply, if a nerve crosses the joint, it innervates it again. Right. Okay. So think again about things in your cubital fossa. Radial nerve is the most lateral. Median nerve, median nerve is the most medial in the cubital fossa. Right? Then of course you have other branches that also supply the elbow joint, like the musculocutaneous, the brachialis, the ulnar, as well as radial nerve. Right. Okay, then movements possible there. I told you that there is flexion and there is extension. Right. Then does anyone know what carrying angle is? Does anyone know what carrying angle is? Sorry? Okay.
Come again, Watson?
What is carrying angle?
I'm not sure, but can I try?
Yeah, sure.
So Karen, okay, it's the angle between the long axes that when you when you extend the forearm, and it should lie, I think, lateral to the same long axis of the arm. I think so.
Okay, not okay. You're close. And usually it measures like how many degrees?
It differs. I think for female it should be 10 degrees, if I'm not mistaken.
Yeah, so it's a range. It's a range up to I think around 15 degrees.
Okay.
Okay. Okay. Do you guys have any specific questions about the elbow joint before I talk about the clinicals?
Why is it average your carrying angle it should differ in males and females? Because number ones in males average
yeah.
5 to 10, in females is 10 to 15.
So females have a greater carrying angle. You're asking, you never thought of anything. Think about your bones, then think about the bones of a female. Do you get it?
Yeah, somehow, but information that ndangweta zvongosangana nayo ndachingoskrolla mapages handinombonyatsoita pay attention. So nangonotice that is really different. So
Sorry?
I'm still looking for reasons.
Sorry, I can't hear you. Okay,
ndachiti madifferences are like ndangosangana nazvo pandachingoscrolla a certain slide.
Differences between
So I
what?
know pay attention to it. I'm still looking for my reasons. My average carrying angles is to say I differ in males and females.
Mhm. Okay. Then clinicals.
Anisu?
Yes.
So you're saying that the capsule is fibrous. Sorry. The synovial membrane is fibrous.
Why?
I'm asking
Um,
because when I'm looking at the course outline, it's saying it states what the synovial membrane is made of, something like that.
so for synovial membranes, if you go back to histology, they have what we call type A synovial or type 1 synovial cells, then type B. Right? It's the type A cells are fibroblast-like cells. They produce fibrous matter. The type mm, the type B, they're macrophage-like, so they do phagocytosis. So yes, it is capsule. It is from cartilaginous, this capsule. Okay.
Okay, thanks.
Okay. Then the clinicals, you can get an effusion, right? Okay. Then there's what we call students' elbow. I think a lot of students, they sit like this in class. They inflame one of the bursa associated with the elbow joint called the olecranon bursa. Okay. There's something called a Nesmed's knee again. Not the knee, but the elbow. More questions on elbow joint. Any question on elbow joint? Okay.